Welcome to everyone, either panelists, experts, or colleagues and friends in the chat. I will talk about the postnatal challenges of hemodynamics in CDH neonates. And while I'm preparing myself, I hope you can see my um, presentation, right? If no, let me know. So we go to the hemodynamic challenges and then talk a little bit about the postnatal management. I will not talk much about the pulmonary management or nutritional aspects and so on. For sedation, I focus really on the hemodynamics since this is the cardiac section. I think that should be fine. If you feel there is not everything covered, let me know in the chat, and I'm happy to go into the discussion afterwards. So the pathophysiology in CDH has long been described as a combination of lung hypoplasia, as Dr. Deprest described very nicely, and pulmonary hypertension due to a maldevelopment of the pulmonary vasculature and the pulmonary arteries. And in recent years, probably in the last decades, we worked a lot on the problem of cardiac dysfunction in CDH. So this really has become a cornerstone in the pathophysiological trifecta, as it is called nowadays. And we have to consider these aspects, and they are really important for management, and has changed also a lot how we approach these kids nowadays. To go a little bit into the physiology, here you can see on the left side the fetal circulation in a healthy fetus. In the middle, it is described for a CDH fetus, and on the right side, it is described for the CDH neonate after birth. And as you can see here in the middle, we usually have a very interesting feature, which is a hypoplastic left ventricle, a very small one, and this might derive from an abnormal ductus venosus flow due to the herniation of the organs into the thorax. So the ductus venosus flow that is in utero usually going through the foramen ovale to the left ventricle and shaping the left ventricle has a different direction, and this might lead to the hypoplasia that we see in these kids. After birth, we have suddenly a loss of the placenta, and which is usually described as a low pressure system, and so an increase in the systemic vascular resistance. And as the baby comes out, we focus a couple of things. And I will go through this, but I want to start first with the description or the definition what PPHN is. And traditionally, it has been described for pulmonary hypertension of the neonate as a disease with failed postnatal transition with a very high pulmonary vascular resistance and pulmonary arterial pressure. So if we look on at the baby with CDH, we have these precapillary anatomic abnormalities in the pulmonary vascular structure, and they lead to an increased pulmonary vascular resistance. So then what we can observe, usually also clinically using echocardiography, is right to left shunting, typically via the patent DA, but also sometimes via the atrium. And additionally, we see a right ventricular dilatation and dysfunction. And with the right ventricular dilatation and dysfunction, we have a decreased pulmonary blood flow. This is also affected, of course, by the right to left shunting via the PDA. And this reduced pulmonary blood flow leads to hypoxemia, acidosis, and hypotension. And hypoxemia itself, as you know, and acidosis are very big triggers for pulmonary vascular resistance. So we kind of go into a vicious cycle in the PPHN babies. And this is the classic PPHN phenotype that we can also see in other diseases. I want to show you this slide. This is also from the CDH study group that shows that PPHN itself, if we put it into certain severity degrees, it is associated with an increased mortality and is really an entity that we have to treat. And but when we consider here the heart and think about what's going on, I want to show you also from the developmental point what the impact is of this LV hypoplasia that we see and how the left ventricle can be impacted in its function. Yeah, so beside the developmental left ventricular hypoplasia, usually due to a ventricular independency, we have changes in the left ventricle as the right ventricle dilates. It can compress the left ventricle, which can further lead to a lower cardiac output of the left side. Additionally, if we have systemic hypotension, hypoxia, and acidosis, this can also affect the function after birth. Then an additional point is when you consider the developmentally small LV, which now has to pump against a high systemic vascular resistance and a high afterload after birth, this can further decrease the capacity of the left ventricle and really make things worse. So with left ventricular dysfunction, we have a reduced systemic blood flow, which again aggravates hypoxemia and hypotension. So this is really pretty much the pathophysiology that we have. And um, from the left ventricular dysfunction, we can see something that is described, and all the people in cardiology and ICU care know about this. And it is the post-capillary pulmonary hypertension. It comes from an increased pulmonary venous pressure, either by left ventricular dysfunction, or you can have it with pulmonary venous abnormalities and stenosis and so on. So when we approach the baby, it is always, for me, from my understanding, good to put it in certain boxes. So we have the pulmonary vascular resistance box that we can treat and approach. We have the right ventricular problem box that we want to treat, and then we have the left ventricular box that we need to treat differently. And how we can do that, I will describe in a minute, because we need to consider these things. And when I approach a baby and I do an echo on the ward, then I always ask myself for how big are the problems in each of these boxes. Here is a brief figure describing the flow, how it goes through the body from the vena cava to the right atrium, to the pulmonary capillaries, and to the aorta. And it is described here again, where you have the precapillary pulmonary vascular resistance, as we can see it from true PPHN or traditional PPHN. And then here is the part where the postcapillary pulmonary hypertension comes in. And when we look on the perspective for the pediatric and cardiac ICU and the cardiologist, we have this statement paper which is already 10 years old, but back then it was already described that for pediatric pulmonary hypertension, and that we as physicians should distinguish between precapillary and postcapillary etiologies, and that is important for the treatment. And this was published by a point where we had in CDH management not fully understand and investigate this. So beside these 3 points, we have different other points which affect the outcome and the physiology: acidosis, inflammation, prematurity, certain prenatal factors, other comorbidities as well, if you have a syndromic or a CDH with a cardiac defect or so, certainly the pathophysiology is something different. In the CDH community, we came to an agreement that we want to define certain pathophysiological phenotypes. And here you can see a graphic from a paper that we published 2 years ago, where we have also a figure describing these phenotypes. So you have typically the normal phenotype in the mild CDH, then you have those who have an isolated left ventricular dysfunction, which can lead to post-capillary pulmonary hypertension. Then you have those with a major or predominant right ventricular problem, and then on the at the fourth phenotype, you have this biventricular dysfunction, and the management for all of these is a little bit different, and I will show you how we can approach this. So what you have to take out is when you approach a baby, and echocardiography is one of the major things how to assess these kids, is that you really have to look for the certain phenotypes. And I don't have the echo covered here in this webinar, because that usually can fill an entire webinar by itself. But it might be good to look for not only for the left and right ventricular function, but also for the right atrial flow, so the direction of the right atrial flow. And typically we can see it as it is described here in the classic PPHN, that we have, at least if when we approach systemic pressure, we have a right to left shunting in combination with the right to left shunting via the duct. And in the post-capillary pulmonary hypertension, usually you see a left to right shunting via the atrium, sometimes even in the context of right to left shunting via the ductus. So you can use that to differentiate a little bit what the problem is, and then further analysis of the left ventricle will help you to get further. So if we talk about cardiac dysfunction, it is really a problem. There are several studies out there. The incidence varies a little bit depending on how thorough the authors looked. We know this from multi-center studies that probably the incidence is underreported, but we say about 30 to 60% have LV dysfunction, and a little higher is the incidence for RV dysfunction. We have published data from the CDH study group a couple of years ago that showed that especially the left ventricular and the biventricular dysfunction has an increased mortality. So we did not see that really for the right ventricular, isolated right ventricular dysfunction, probably because we can see it so often in the CDH babies, but in those with a dysfunction of the left ventricle, the mortality was twice as high as in those without. So this is really a thing. And we have to say until today, we don't have any established criteria how to measure it. I think strain is quite a good thing how to do as a tissue Doppler. They all have their pros and cons. So we try to come to an agreement in the international community, but the parameters we defined are very limited. Also, other markers like biomarkers are not really in that way that we can recommend it. Here you can see all the different parameters that are described in CDH for echocardiographic assessment. So this is really, there's a lot of academic research out there, and I think it is you have to stay basic for your assessment if you approach the baby clinically. Then left ventricular hypoplasia, that is really an issue. This has been described in a paper that has been published by Flaminia Pugnaloni, who was a research fellow back in Bonn when I worked there. And we were able to see that in the babies with left ventricular hypoplasia, the mortality is about almost 50% compared to babies with normal left to right ventricular size. So what we did here in this study, as the red dots, you can see the right to left ventricular diameter in healthy newborns, preterm and term babies. And then the little pyramids are where the CDH non-survivors, and the squares the CDH survivors. So this is really something that affects the baby and has confirmed also by other groups. So we have a couple of things that we can approach, and I want to guide you through this. Important is to recognize that these problems are not there the entire time of the stay, but they change over time, and they can also change. The phenotypes can change sometimes even within hours. Typically, left ventricular dysfunction is seen very early and resolves after a couple of days. And if we can control the pulmonary hypertension, that's great, but we can also sometimes see this persistently. So first line treatment for pulmonary hypertension is nitric oxide. We use it a lot. Interestingly, there are no studies out there who show a survival benefit. In the 1990s, there was the NINEOS trial that showed even a higher rate of ECMO in those babies that were randomized to nitric oxide. And there were several other studies, registry studies, and so on, that showed a certain harm potentially for the baby. We assume that it might be that especially those babies with left ventricular dysfunction were those who did not respond. And the rationale behind this is to think, okay, if we increase the pulmonary venous return by lowering the pulmonary vascular resistance, that might be harmful for the not well pumping LV. So always start this with caution, and if the baby deteriorates, it might be an option to stop the nitric. And similar with sildenafil, that has been described. Here's a paper that I published from my group, and we saw a positive response in about 40% of the CDH babies. Again, here, those with cardiac dysfunction had a much lower response than those with cardiac dysfunction. So again, it might be a thing for to be cautious about. And then in the matter of time, I will briefly go through this. Endothelin, one has been described in the past as being associated with worse outcome in CDH. Also study from my former institution where we saw that in non-surviving CDH babies, we have at certain time points after birth increased values, and these increased values were associated with pulmonary hypertension at birth, but also with pulmonary hypertension after 14 days. So we over the time we treated quite a substantial amount of babies with bosentan as an ET1 receptor antagonist. And in these 50 patients, we were able to see an improvement of pulmonary hypertension when measured by the echocardiography in 50% after 1 week and in 72% after 2 weeks. So there is a certain effect. There might be some more selective ET1 antagonists out there, but there's no data in this yet. Then coming to the cardiac dysfunction, use of inotropes. We know cardiac dysfunction is a problem. It is associated with increased mortality, so we need something to improve the cardiac function. And here are a few agents that are increasingly used. Milrinone, there has not much data out until I think 2 or 3 days ago, where the first results were presented at the last PAS meeting, and milrinone might improve the oxygenation in some babies. So we are getting increasingly data in the next couple of months or years. Epinephrine is often used, dobutamine is often used, dopamine is used quite frequently in the US, but there is a decline for some good reasons. And and we personally use quite frequently levosimendan, which helps to improve the cardiac function in these babies. So here's some data on the levosimendan. It has been published, and so you can read it. It is associated with improved oxygenation within the first 24 hours after starting the medication. In my experience, the babies remain pretty stable during the infusion. We skip the bolus that has been described somewhere in the literature and start on a baseline infusion rate. With this, you are able to remain a pretty good blood pressure, and it takes a couple of hours, that's at least my subjective feeling, until it works, but it's a good addition if you use it either in combination with epinephrine or with dobutamine. So very briefly about the effect of ventilation on the heart. It can affect certain things. So if you have an increased alveolar pressure, you might be in a situation where you increase the pulmonary vascular resistance of the baby. Then also with an increased intrathoracic pressure, you can have effects on either the pulmonary venous return and also the RV preload, which can impair the function, and it has also an effect on the left ventricle. There is a nice publication from Aaron Siegel. He's describing this in preterm babies. It's really worth reading it, and I can only recommend it. We cannot go through all the effects at this point due to the timing, but I want to show you a very few data on this, and then I'm done. Here you can see a slice of the alveolus and how the vessels are surrounding the alveolus, and with increased intrathoracic pressures, we can see an overdistension, which may lead to compression of all these vessels and reduced capillary blood flow, which might be a problem, especially in kids where you have pulmonary hypertension. And we were able to see in a study where we measured the relation of overdistension and atelectasis in a subgroup of babies with CDH, that probably the PEEP that we usually use of 4 might be too high for a certain proportion of kids. So very preliminary data, and we have to wait for confirmation studies, but this is something that I at least recommend to use if you have a deteriorating patient and pulmonary hypertension as a major focus. Reduce a little bit the PEEP with remaining a similar driving pressure. And this might sometimes lead to an improvement in the oxygenation. So now I'm coming to an end. Here is a summary of what I just said, and we were putting this in this figure. So this is something that I have also here in my hospital for the staff that to read it, to always think about this. And I think this is something that is important if you train your team or your colleagues in how to approach the babies, that you always go through is, where is the problem from the respiratory side? Can I improve something? Do I have RV dysfunction? Do I have LV dysfunction? Or do I have a certain combination? And with this approach, you might be able to improve the care of these babies. For the future, we have some problems or some issues how to improve the echocardiographic measurements. And now I'm at the end, and I'm looking forward for the discussion. Thank you very much, and apologies for taking too much time.